Dr. Masarova, you were in New York recently for the MPN Congress. Can you share some highlights from that meeting?
Yeah, sure. That was a very interesting and very loaded conference, full of experts and a great data. I really liked the overall excellent update of all the therapies that currently exist in the MPN space, including polycythemia vera, essential thrombocythemia, myelofibrosis. So really a broad breadth of JAK inhibitors, their current sequencing, combinations, interferon updates. I very much like also the focus of the novel therapies, which actually talked about, for example, the development of the antibody against mutant calreticulin, the PIM inhibitors, and a couple others. They are very promising in the space. There were also very, very relevant clinical data. I think I really enjoyed the radiation in hematopoiesis topic. It spurred a lot of discussions in the room. Also, fantastic talks about clonal hematopoiesis and its role in patients with myeloproliferative neoplasms and cancers overall. Very great data on artificial intelligence because that will be a very needed tool, but also very worrisome tool at this point until we learn how to use it to help our patients. But that showed a very promising effect and ability for us to, for example, predict thrombosis risk in polycythemia vera patients, or to distinguish patients with ET versus prefibrotic myelofibrosis, which is still a subject to lots of basically subjective analysis from hematopathologists. And also the poster session was quite striking and really excellent. You could walk around and see so many interesting data, the matched indirect comparisons of JAK inhibitors, particularly the latest approved momelotinib, as it compared to safety data with the currently existing fedratinib or pacritinib.
When it comes to MPN research and emerging treatment options, what are you excited about specifically?
There's a lot of excitement in the field currently, and it really depends how we put these patients in, as I would call, boxes, but I don't like the term. We have these less aggressive diseases such as polycythemia vera and essential thrombocythemia, where I'm really excited about the role of interferon. With the approval of ROPEG interferon or ROPEG interferon in United States as well as Europe, we have opened the door for learning how can we do better. It is approved for polycythemia vera patients. There are currently clinical trials running in essential thrombocythemia patients, a little bit in patients with prefibrotic myelofibrosis. That's an agent that has an ability to go after the disease clone and hopefully eradicate or prevent it. Especially exciting in the terms of preventing it from progression. Then iron metabolism modifier, hepcidin mimetics, other agents impacting this. It's very important. We finally learn how iron plays the role in these patients and how we can actually improve. Very important area in helping patients requiring phlebotomies and hopefully altering the whole disease outcome in the long term. For myelofibrosis, we live in an era of JAK inhibitors. We are so excited to have 4 currently approved. I'm more looking forward to the combinations where we have now safer and less cytopenic agents that have a role in anemia or thrombocytopenia, and hopefully will be able to be combined with others. So we could even move the field more into other hematologic malignancies, where in myeloma we use 5, 6, 7, 8 drugs, where myelofibrosis we still advance. So I think we have still a lot to do. And then non-JAK inhibitor combination, non-additive inhibitor compounds or mechanism of action really tailored to the disease pathogenesis. Calreticulin, excellent topic, which I'm saying maybe in a couple of years, we will be really classifying myeloproliferative neoplasm calreticulin mutated versus JAK2 mutated, and we will not be calling them one, because hopefully we will find a tool to eradicate the calreticulin and to really be able to offer ultimate, what I call ultimate cure. So that is something really exciting to come, and all of these investigators in MPN fields are so eager to see whether the preclinical data we have seen are going to stand in our patients. That would be really fantastic.